Good afternoon, and thank you very much for the invitation to be part of this very important conference. I'm also very happy to represent my medical society, the Philippine Society of Endocrinology, Diabetes, and Metabolism in this conference. The title of my lecture is Pre-Diabetes, Don't Sugarcoat It. This is a lecture on the screening, detection, and management of pre-diabetes. I'm Dr. Cecil Jimeno. This is my conflicts of interest declaration, and I believe I don't have any major conflicts of interest with regards to this lecture. Now, the whole 9 yards is actually a term that was inspired, that has inspired a movie that starred Bruce Willis. This American term, though, refers to doing things all the way. And so this afternoon, I will not have a lecture on pre-diabetes for dummies. And hopefully you recognize that pre-diabetes is not just a simple form of diabetes, but that we need to do things to the fullest extent possible to manage pre-diabetes, because after all, managing pre-diabetes is all about diabetes prevention. This is the outline of my lecture. I have 7 bullet points, and straight away we'll begin with the definitions and criteria. So what is pre-diabetes? It's a term that refers to an intermediate form of hyperglycemia, which is based on glycemic parameters that are above normal, but are still below the diabetes thresholds. It's a practical and convenient term that refers to impaired fasting glucose, or IFG, impaired glucose tolerance, or IGT, and a glycated hemoglobin that's already above normal, but not yet within diabetes. And these terms are important because they predict individuals or high risk of developing diabetes and its complications. Therefore, this term, prediabetes, identifies, actually, this is the earliest identifiable stage of glucose dysregulation, because your sugars are already elevated, although they're not so high for you to diagnose yet diabetes. And most people with this condition will develop type 2 diabetes within 10 years, and that's why it's important to recognize them. And it's a term coined in the 70s as a result of better understanding of the natural history of diabetes, especially type 2 diabetes, where we realize that in type 2 diabetes, the pathology does not begin at the diagnosis of diabetes, when the FBS, or the 2R post-meal glucose, or the 2R blood glucose in the OGTT is already going up, and there's already beta cell failure. The problem starts actually 10 to 15 years prior to diagnosis, when there's increasing insulin resistance that's initially met by hyperinsulinemia, an increase in the beta cell secretion. But over time, the insulin resistance plateaus, but beta cell failure begins to happen. And this is the point when the FPG, or the post-meal glucose, starts to go up, even prior to the diagnosis of diabetes. And again, complications, whether micro or macrovascular complications, can already develop at this point. So this particular figure actually reflects many epidemiologic studies and measurements that have been done across different populations. And this is from the UK Whitehall study, where they actually saw that if this is time 0, the diagnosis of diabetes, where FPG is now more than 126, or the 2R is more than 200. Here again, you notice that insulin sensitivity is going down, meaning increasing insulin resistance practically 10 or 15 years prior to the diagnosis of diabetes. And that initially the blood sugars don't really go up, because beta cell function still rallies. No, there's an increase in insulin secretion, some form of hyperinsulinemia. But over time, beta cell function does go down. There's some beta cell failure. And so by the time you're diagnosed of diabetes, your sugars are very high. But before that, there's this intermediate stage, and that's pre-diabetes. Now, the diagnostic criteria for pre-diabetes there are actually 5 different criteria. And these 5 are based on 3 tests: the FPG, the 2R blood glucose in the OGTT, as well as in the A1C. The WHO does not use A1C because of lack of access, the lack of knowledge about the prevalence of hemoglobinopathies internationally, while the IEC does not really use FPG and the 2R blood glucose. The IEC is the International Expert Committee on Diabetes. And so we have 5 different criteria. The ADA criteria are typically much lower. In the FPG, it's 100 to 125, and the A1C is 5.7 to 6.4. The 2-hour blood glucose in the ADA and WHO are the same. It's 140 to 199, while the FPG in the WHO is much higher at 100 to 125, while in the IEC, it's a much higher A1C. So 1, 2 based on the FPG, 3 based on the 2-hour plasma glucose, and 2 more for the A1C criteria. And so we realized that internationally, the various national organizations would adapt either the WHO or the IEC or even the ADA. In the Philippines, we have tended to follow our American counterparts, so that our IFG criteria is 100 to 125 versus the Canadians, which tend to follow WHO. Our IGT criteria is the same across different organizations, while again, our A1C criteria coming soon will be much lower following the American Diabetes Association. We're currently in the process of developing our Philippine practice guideline, revising our Philippine practice guideline, and this should come out before the end of the year. So we realize again that pre-diabetes is an intermediate stage between normal glucose tolerance and diabetes, and the continuum of sugars is, this is based on a continuum of sugars, as well as a continuum of risks, as well as complications. And that in the Philippines, we tend to follow our American counterparts in that in the FPS, our pre-diabetes IFG criteria is 100 to 125. Our OGTT 2-hour blood glucose is the same as others, 140 to 199, while coming soon, our A1C criteria is again following ADA at 5.7 to 6.4. And so we move on to our next bullet point, which is screening and diagnosis. And we realized that in the Philippines, in the last Unite for Diabetes Practice Guidelines, we said that not all adults should undergo universal screening using laboratory tests. The first thing that has to be done is to clarify their age, and we do not indiscriminately do lab tests at any for asymptomatic adults, but we evaluate annually for risk factors for type 2 diabetes and diabetes. And so what we have said in the past, in the Unite for Diabetes Practice Guideline, and even in the current PHEX, or the Philippine Guidelines on Periodic Health Examination, we screen all apparently healthy adults 40 years old and above for pre-diabetes and diabetes. But like I said, coming soon in our revised guideline, we would lower the cutoff to age 35. So we will say screen all apparently healthy asymptomatic adults beginning at age 35. And if they're younger, if they have even just one risk factor, you should also screen using any of the laboratory tests. And so what are these risk factors that must be evaluated annually? Even if they're negative now, you evaluate it annually. So the first would, of course, be women who have PCOS or a history of gestational diabetes or delivery of a baby who is large for gestational age. Overweight or obese individuals, whether using the BMI, waist circumference, or waist-hip ratio. Those with a family history of first-degree relative for type 2 diabetes and have sedentary lifestyle. And those with one or more of the criteria for metabolic syndrome, including hypertension, low HDL, low triglyceride, or clinical manifestations of metabolic syndrome, such as acanthosis nigricans or the hyperpigmentation in the nape area. Now, we also include in screening those persons who have diseases that predispose them to developing diabetes, or for which picking up diabetes or pre-diabetes early will have a major impact in the outcomes of these diseases. And this includes tuberculosis, schizophrenia, as well as chronic autoimmune rheumatologic diseases such as LE or psoriasis. Again, risk factor screening annually, and what we are going to recommend closely follows international criteria, where the recommendation is now to screen at age 35, beginning at age 35. So we will move on to the epidemiology of pre-diabetes. And for that, we go to the International Federation 2017 Atlas that have told us that around 7.3% globally have pre-diabetes based on the IGT. That's equivalent to 350 million individuals. And if you take a look across the different age groups, you can see whether men or women across the ages, it just increases, the prevalence just increases. But in terms of the actual numbers of people with IGT, whether it's 2017 or 2045, it appears that it's between ages 50 to less than 65 that have the highest numbers of people with IGT. And looking at the list or table of the top 10 territories for who have the most number of people with IGT, we can see some of our neighbors in Asia, including China, Indonesia, India, even Japan and Thailand. That's 2017. And for 2045, still China up there because that's where the most number of people are, Indonesia, as well as Japan down there. Now, in the latest 2019 release of the IDF, from 7.3, it's now 7.5%. But what we're actually taking note of here is the fact that about half or 48% of persons with IGT are actually less than 50, and a third are less than 40 or between 20 to 39. And the majority live in low and middle income countries, much like the Philippines. So people with prediabetes are relatively young and they reside in LMICs. In our local data, we do have the National Nutrition and Health Survey to take a look at. And here we can see that as of 2019, we have an 8% prevalence of diabetes. This is just based on one FBS determination. Now, in terms of the estimate for IFG, again, because only FBS was taken, it's 9%. But this is based on the WHO cutoff of 120 to 125. And so if we change it to the ADA cutoff, 100 to 25, it jumps from 9% to around 29%, more than 3 times the prevalence of diabetes. And so we see that across the years, pre-diabetes rate or incidence is just really rapidly increasing, especially since the 2010 onwards. And this then parallels closely the rapid rise in the overweight and obesity prevalence in the Philippines. So that now we say that 1 out of 3 adult Filipino has pre-diabetes, but that this might be an overestimation because we didn't really do the FBS twice, nor did we do an OGTT. Now we take note also, and this is something to think about, that there are many criteria, and depending on the criteria that you use, you might find that the epidemiologic prevalence might be a bit different from what we see in the clinics because we follow our guidelines. And here we can see that across the different diagnostic criteria, it's actually the ADA fasting glucose criteria, and this is based on the US population that has the highest yield. The next criteria have more or less the same, and the least yield comes from the IEC A1C criteria. So an author has concluded that there's presently a problematic disconnect between how prediabetes is defined in clinical practice and now it's actually estimated in epidemiologic studies, taking note that is the ADA IFG criteria that has the highest yield in terms of prevalence. So we move on now to the significance of early management and recognition, as well as prognosis and monitoring. And we realize that we need to diagnose prediabetes early and manage accordingly because earlier identification may lead to diabetes prevention. Looking at persons who have IFG at baseline and following them up over 2 to 12 years, the cumulative incidence of diabetes is around 2 to nearly 40%. And if you follow them up longer, it's around 30%. If you take a look at the annual conversion rate of pre-diabetes to diabetes, it's around 5 to 10%, again, varying by population according to criteria used. In a meta-analysis done in 2004, they've seen that it's the combined criteria of IFG and IGT that has the highest conversion or annual incidence rate of diabetes. And if you look across different studies, whether it's in the US or in Japan, again, different conversion rates of pre-diabetes to diabetes. But keep in mind, generally around a 5 to 10% conversion of pre-diabetes to diabetes, annual conversion rate. Looking at the lifetime conversion rate, an ADA expert panel estimates that 70% of individuals with pre-diabetes will eventually develop diabetes. In the Chinese diabetes prevention program, where they followed up participants over a 20-year period or longer, and they kept repeating the OGTT, they found an even higher conversion rate of more than 90%. And for women with GDM, the conversion rate of pre-diabetes to diabetes is around 20 to 60% for 5 to 10 years after pregnancy. And again, the numbers are all different because of the different criteria that is used to define pre-diabetes, GDM, and even type 2 diabetes. Now, are we able to then revert from pre-diabetes to normoglycemia? Now, for this part, there is more, there's really sparse data, but the meta-analysis that have been done, whether short-term or longer-term, seems to say that it ranges from around 15 to 30%. In another study where they took a look at persons with IFG, the 10-year reversion rate to normoglycemia was around 55%, so pretty good. No? Now, so that's the first reason why we need to identify prediabetes early so that we can revert them back to normoglycemia and prevent diabetes. But the second important reason is that early identification leads to prevention of adverse outcomes. And if you take a look at persons with prediabetes, they already have a high burden of cardiovascular risk factors. In a US NHANES cohort, the estimated 10-year CV event risk is around 7%. And in this NHANES cohort, they had a high prevalence of hypertension, dyslipidemia, smokers, as well as those with, even some have already reduced EGFR and albuminuria. And I like this illustration of the iceberg just to point us toward the way towards really managing pre-diabetes. No? The ship is nearly hitting the tip of the iceberg. And by this time, it might be too late, no, when we begin to treat only at the point of diabetes. If we treat them at the first instance when we already are able to see elevations of blood sugar, even if they're not still within range of diabetes, we can prevent macroangiopathies, cardiovascular diseases. We can prevent microangiopathies, no, or retinopathy, nephropathy, or neuropathy. And if we take one more step and actually do primordial prevention, when the sugars are not yet elevated, but they already have risk factors, either because of genetics or because of the environmental risk factors like our diet or lack of physical activity, if we intervene at that point to reduce weight, to reduce our lipids, for example, then that's primordial prevention, which can, of course, prevent the progression to pre-diabetes and its complications. So early identification of pre-diabetes will really lead to prevention of adverse outcomes. And this meta-analysis, no, if you have pre-diabetes, the risk for CV diseases is as much as 1.3 relative risk, and all-cause mortality 1.1 to 1.3 also. If you identify pre-diabetes and treat accordingly, you might prevent retinopathy, peripheral neuropathy, and even chronic kidney diseases. And what we have seen is that no matter which diagnostic criteria you use, if you apply them to the population, and this is in a community-based ARIC study, that any of the criteria can help identify future development of incident diabetes, development of chronic kidney diseases, cardiovascular diseases, and all-cause mortality. And it is the one that has the lowest yield, no, for pre-diabetes that actually performs best, the IEC criteria. So you notice highest prediction for incident diabetes, CKD, CVD, and all-cause mortality. And as recent as June 15, there's news that pre-diabetes may already be an independent risk factor for MI. So moving on in our outline, no, we go to the management of pre-diabetes and realize that the primary approach is non-pharmacologic. It's really lifestyle intervention. Landmark clinical trials have already shown that intensive lifestyle modification aimed at reducing weight by 5 to 10% through dietary intervention and physical activity are really the major interventions for pre-diabetes. These trials have been conducted in various settings, China, Finland, US, and India, and show that over a 3 to 6 year period, you can reduce the incidence of pre-diabetes by around 30 to 60% versus placebo or minimal interventions. And in most of these trials, except for the Indian study, the effects were mediated primarily by weight loss. And since then, it's been tested in other Asian populations like Taiwan, for example, or Japan, and have also been proven to be effective. So just very quickly, to just show you the different trials, this is the Chinese Dachshing study, the Finnish Diabetes Prevention Study, the American Diabetes Prevention Program, and the Indian DBP. These were the years of the study. They were mostly IGT, except for the American DPP that included ADA-IFG criteria. They were relatively young, except for the Finnish one. The study arms were mostly diet and exercise, or a combination. And it's in the American DPP where metformin was introduced, no? Or metformin was combined with diet and exercise in the Indian DPP. The weight loss targets 5 to 7%, and the mean follow-up ranged from 2.8 to 6 years. If you look at the effects in terms of the risk reduction for diabetes, you can see that hands down, diet and exercise work best. Here, comparing metformin head-to-head with diet and exercise was almost twice as effective as metformin alone. And metformin was combined with diet and exercise. There was no additional benefit. Now, if you again take a look at the long-term benefits of this lifestyle intervention, you can see that for both the US and the Chinese trial, after they were already out of the clinical trial and they were followed up for 10 to 15 years or over 20 to 30 years in the Chinese study, we can see that there was still persistent benefit in terms of reduction in incident diabetes, blood pressure, triglycerides, LDL. And for the Chinese Dachshing study, which took longer, not only is incident diabetes still reduced even after they were already out of the trial, but there was a decreased number of CV deaths, all-cause mortality, and even severe retinopathy at year 20. This is an example of the sample dietary intervention for the US DPP. They were aiming at reduction of total calories as well as fat following the US Food Pyramid Guide. Again, the aim is for an initial weight loss of 70% of baseline, and their calorie goals is just to calculate the daily intake and then subtract 500 to 1,000 calories per day, aiming to achieve a 1 to 2 pound per week weight loss over a 6-month period. The fat goals were calculated based on 25% calories from fat, and they were given 4 standard calorie levels over a 6-month period as follows. The physical activity recommendations is similar to what is currently recommended for diabetes or pre-diabetes, which is aerobic physical activity of at least 150 minutes per week of moderate to vigorous intensity, spread out over 3 days over the week at least, with no more than 2 consecutive rest days between bouts of activity. And what we've learned from this diabetes prevention trial is, number 1, there is a legacy effect or a metabolic memory. This is a term that is used for the persistent benefit of the in-trial effect in these lifestyle intervention studies, even after the clinical trial, which was not found in the pharmacologic approaches. No? In the drugs, after you stop them, there's a rebound of the hyperglycemia. They just go right back to pre-diabetes. Drugs do have metabolic memory, but only in early diabetes, not in pre-diabetes. Again, emphasizing the fact that the earlier, the better. When you introduce interventions earlier, this leads to robust and longer lasting effects as compared to when they're implemented later in the life course. And no matter what the criteria used to identify pre-diabetes, there was really benefit for lifestyle modification as the first-line approach in persons with pre-diabetes. Not to say that the drugs don't have any effect. They do, especially for metformin. Except that, like I said, there is rebound hyperglycemia and there's no persistent effect after they're out of the trial. So whether it's metformin, the TCDs, the alpha-glucosidase inhibitors, acarbose and voglibose, or even liraglutide, there was really benefit in terms of diabetes risk reduction. Even for the anti-obesity drug or the stat, because of the weight loss that was seen with it, that was demonstrated in the SENDOS RCT done in 2004, a 4-year trial, they showed that those who completed treatment, who have pre-diabetes and IGT, really have a 30% also reduction in relative risk of diabetes. So you can combine, for example, this drug maybe with diet and exercise. There's also one clinical trial for phenofibrate, but because it's a small short-term trial, it's not really yet recommended. But again, there is regression to normal glycemia compared to placebo. The antihypertensive drugs, the RAS blockers, ARBs, as well as the ACE inhibitors, also do have some diabetes prevention that we've seen in the secondary analysis of hypertension trials. But because the effect of these drugs is much smaller than that of the anti-diabetic drugs, they're not really recommended for the treatment of pre-diabetes. The other adjunctive therapy that we can use for morbidly obese individuals with pre-diabetes is bariatric surgery, where the 2 to 10-year incidence of type 2 diabetes was significantly less, along with the reduced risk of cardiovascular diseases among the morbidly obese. Now, just some words about metformin. Again, to emphasize that in the US DPP trial, metformin was overall less effective than lifestyle modification. But at least for pre-diabetics who had a BMI more than 35, it was as effective as lifestyle. Metformin was also more effective among younger individuals rather than older individuals, and among pre-diabetic women with gestational diabetes, metformin and intensive lifestyle modification had equivalent effects. And this is the reason why in many practice guidelines, including the American Diabetes Association, we identify subgroups where metformin might be recommended along with lifestyle intervention. And they include those who are relatively younger, 25 to 59, BMI of more than or equal to 35, higher FPG or higher A1C, and in women with gestational diabetes. And metformin has the strongest evidence base in terms of long-term safety. And although there's no pharmacologic agent that's recommended, metformin seems to have the greatest benefit versus risk. And if therefore you're going to use other drugs, again, consider the risks versus benefits. Like the TCDs, they do tend to cause some weight gain. And again, just to emphasize that pharmacologic therapy is not first line because lifestyle interventions had better and longer effects. Drug effects tend to wear out after a washout period, and there's no additional benefit over lifestyle in some of the clinical trials. And long-term benefit has not really been seen among the pharmacologic agents. So just then to wind up this lecture, what are some of the challenges and conclusions in terms of translating the evidence on diabetes prevention in practice? So some of the caveats of the diabetes prevention programs is that they're resource and labor intensive. The lifestyle interventions that were tested in the DPP trial consisted of 16 individual sessions taught by case managers who were all sorts of specialists, nutritionists, exercise physiologists, or behavioral psychologists during the first 6 months of the intervention, followed by core sessions twice monthly in person. So this is resource and labor intensive, potentially costly. They need multi-stakeholder collaboration, and therefore it's hard to translate. The current recommendations, for example, in the ADA, recommend referral of individuals with prediabetes to intensive behavioral intensification program, annual monitoring for the development of diabetes, and use of metformin among individuals with higher BMI or younger and women with prior GDM. But even in the US, there's a lack of diabetes prevention programs. The detection and treatment rates of prediabetes remain low. Patients may be referred to their national DPP lifestyle change programs, and the insurance coverage is expanding but remains limited. Metformin is hardly prescribed in daily practice, even in their largest health insurance company. And some of the obstacles for managing prediabetes really is the lack of standardized approach in screening, limited screening, the cost of the interventions, and really translating the real world, translating the interventions into real world practices that have to do with behavioral interventions. After all, losing weight, dieting, and physical activity are really the hardest to do. And so in the Philippines, if we should translate the evidence, and if we want to go the whole 9 yards for pre-diabetes, we need to develop practice guidelines. We're doing that. We need to craft a comprehensive diabetes prevention program. We need to capacitate non-doctors, nutritionists, dietitians, gym, lifestyle coaches to be part of diabetes prevention programs and even to be part of the network for UHC. The LGUs are already starting to initiate healthy lifestyle choices, parks, bike lanes, healthy spaces, and we look forward to the universal healthcare, where treatment, screening, prevention will not just be hopefully for diabetes, but including pre-diabetes. Only by doing all this would we have gone the whole 9 yards for pre-diabetes in the Philippines. So thank you very much. This is my email, and you can reach me also in this Twitter handle. Thank you very much for your time and attention.